So who wants to go first? I've got a hand at the back.
My name's Barry Faith, good evening. I've got a question I'd like to ask, but which has got a specific example that may help in answering it. And the question is, what are the key constraints affecting what this review decides? And the example I've got, and I think it's quite important that these constraints are known at an early stage, the example I've got is to what extent will or can national bodies such as NHS England, government, quangos such as Monitor Care Quality Commission and the Competition Commission constrain or intervene in any reorganisation of services that is deemed as needed by this review?
The thing is, yes, a national body may try to intervene or may have the ability to intervene with anything that we're trying to do. What I would say is that nationally, there is interest in what we're doing down here in Dorset. And so actually, when you look at or talk to NHS England and you talk to other national bodies at the moment, they're actually very interested in us being successful in doing this, because actually we have taken a very proactive stance in doing this, because at the moment, you'd have seen some of the financial figures. This is the first year that our hospitals locally are overdrawn, if you like. Now, there are other areas in the country which are already much further down that line and have a much sort of more parlour state as far as their finances go. We don't want to get to that situation. We want to act now. We want to do something now so we actually stop that from happening. So yes, they can intervene, but actually we're getting lots of encouraging noises at the moment to say, look, we want you to be successful in doing this, because actually if you do, we're going to copy this across the country and get other people to do it across the country.
Hello, my name's Kelvin Trevitt, and I'm speaking for myself and not an organisation. How can people actually point out, what's the best way people can point out wastage in regards to what happens in hospitals? I'll give you an example. At the moment, I'm spending a lot of time seeing different consultants, and I'm constantly getting letters. I go into hospital once a week, I'm still getting a weekly letter. To me, that seems an absolute waste of money, and the amount of money you're spending on postage appears to be ridiculous.
Yeah, I mean, in terms of inefficiencies, and you've already seen me talking about, it's one of my sort of personal soapbox issues is the IT side of things, in that if we have an integrated system, which we're going to look towards across the whole of Dorset, then actually what we'd be looking at doing is cutting down on this wastage in that sort of issue. In the more general sense, I think if there are any issues about inefficiencies, then there are two ways really. Either it's worth highlighting those back directly to the organisations that are responsible for that. If you wanted to come through our health involvement network as well, we could also try to get some answers for you too. Okay.
My name is Roger Parsons. I am a hospital governor. Do you accept, in a hospital context, the concept of establishment of centres of clinical excellence rather than multifunctioning right across to Dorset?
What we're doing is we've talked about analysing the clinical information that exists in Dorset to date, and we've talked about bringing the clinicians together, which Simon and I have talked about. What we're also doing is bringing in all of the best practice national guidance, and one example of which would be something called the KEO review. And what the KEO review is looking at is what is a really good way of delivering for the top 1 or 2% who need really serious A&E support. How do we best do that? And KEO talks about a centre. So what we're doing in terms of centres of excellence, we're thinking about what is the right way of delivering the services for what the patients need. So we're absolutely taking centre of excellence thinking, we're taking what the colleges are recommending, we're looking at what best practices in Dorset, and one of the things I don't think we probably haven't stressed enough is the healthcare in Dorset that we currently enjoy is above the average for the country. So we're not talking here about we're in a dire strait from healthcare, but there are definitely a smarter ways of making this work, and certainly centres and how we look at centres would be one of those. So stroke, for example, would be a good example of, if you put your stroke expertise in one place, you can deliver a better services for stroke within the budget that we currently have, and we can address the balance really quickly from Dorset being below the national average to Dorset being significantly above it.
And just to sort of add on top of that, really, the sort of notion of very specialist care, there's already precedence for that anyway. If you just take the example of pancreatic cancer and operations for pancreatic cancer, if you need that operation, you have to go to Southampton for that. And the reason for that is it's such a highly specialised operation. It's felt that the consultants need to be doing above a certain number per year in order to be considered sort of trained or highly trained enough to be able to perform that operation. And so we're looking at other areas with similar areas of high speciality that may need to be focused in one particular area.
Hello, Councillor Carol Evans, Vice Chair of Health and Children's Services within the borough. I'd like to ask Frances, she mentioned about carers in your survey. There was no mention of young carers. We have a lot of young carers in Poole, which I'm sure you're aware of, and I'd like to think that they were consulted at the same time.
Thank you for raising that. That's a very, very important area. I've started working a lot more with young people since we started this review. I've already met with the 0 to 19 Forum. I'm met and I'm working closely with Dorset Youth Association and also with Dorset Youth Council. Dorset Youth Council are helping me to co-design a poster so we can get out to young patients, young people, young carers, so that they can have an awareness of what we're doing, so that when we get to the summer, similarly as I said earlier about talking to you, so you've got an understanding, so they've got an understanding of what we're doing and why, so that when we get to the summer they can take a meaningful part in the consultation. We've also got a planning forum with a group of about 20 patient and carers, young people, next month, so they can co-design the consultation with young people and young carers with me, so that one of their suggestions is that they'd quite like to do a conference for young people, young patients, young carers, bringing them all together, and they'd like to run it, and they'd like to do the breakout sessions, the whole lot, and for me just to kind of be there in the background. So, and they also want to do lots of things on social media, Facebook and so forth, because that's their way of communicating. So thank you very much for raising it. And when I gave my brief overview, I obviously wasn't talking about everything that we're doing, and that's a very, very important element of it. And we'll definitely make sure that that's included. So thank you very much.
Thank you very much. I'm Jane Bell, and I chair the Wessex Local Eye Health Network. So I'm looking at the bigger picture for eye health across the whole of Hampshire and Dorset. There has been an eye health needs assessment carried out in Dorset, looking at preventable sight loss and services for visually impaired people. And there are currently over 30,000 people living with sight loss within Dorset, which is likely to rise to 35,000 by 2020. The statistics are quite scary because there's 1 in 5 people aged 75 and over who are living with a certain degree of sight loss. So when you're putting together your models of care, can I please put in a plea that you do consider eye health as part of it, because it is absolutely vital if you're looking at falls, dementia care, healthcare in general, because it's reading labels on foods and medicines, etc., and making sure just people have the right glasses. And as part of your wider IT, I agree completely, we need much more integrated care, and that's particularly important for eye health. And don't forget the community optometrists as well as the pharmacists and dentists.
Sure, thank you for that. Yeah, I mean, we, in terms of the review is including everything. So it is at very high level, so we're not going to get down into the nitty-gritty of particular necessary specialities, but everything is being considered in the round, okay?
Excuse me. Hi, my name is Chris Newell. This goes along with what Jane was saying. I'm chair of the local optical committee. And Simon, you said if something needs doing, you may as well get on with it. Over the past, well, probably 10 years, but certainly over the past 2 years, the CCG, GPs, optometrists, and the eye departments from the hospitals have been looking at redesigning eye health services. We've come up with a plan. The CCG, we're going to adopt it, and then we've been told, no, it's not going to happen until after the clinical services review. You've already had the best people looking at this, and you've got the plan. Can't we just go ahead with it?
I think the thing about this, the clinical service review, because it's looking at everything, it's now looking at interdependencies. And one of the things in the past, we have looked at things in isolation. And so there is a risk that you do look at things in isolation and then miss the bigger picture. And so I'm not saying that we wouldn't go ahead with what you're proposing at the moment, but by considering the bigger picture, it might be that we're missing something. Now, you are presumably going to know a lot more in-depth detail about this than I am. So, I can't really argue against you or do anything from that point of view. But what I would say, if it makes sense, then yes, we'll go ahead with it.
Yes, my name's Peter Clark. I was talking to somebody this evening. The question really is, what about the role of the GP? This person had a wrist problem, been referred by the GP to the hospital. The treatment wasn't satisfactory. She had to go back to the GP 2 months later. Of course, saw another GP who referred her to a specialist. Eventually, treatment was made, and she had to go back, and then again saw another GP, all in the same practice. And her comment, she's an intelligent one, was that the role of the GP is becoming a glorified distribution centre. Now, we know that the GPs are under pressure, and this sounds as if it's a very critical question, but we also know that what the public values about a GP is having somebody that has an overview rather than is just a specialist. After all, if you want just a specialist, you go elsewhere. So, are GPs losing that part of their role that the public most values?
I think I can answer that. GPs are gatekeepers for health and remain so, which is why we have one of the most efficient health systems in Europe and in the world. I think GPs are the last generalists, general physicians, while specialists are specialising even more. Orthopaedic surgeons just do knees or shoulders or hips. GPs are perhaps amongst doctors the last generalists, and I think they do have an overview of complex medical problems that their patients, a more holistic view that looks at all their needs, whether psychiatric or social care. And GPs are also gatekeepers. I think the story you were rolling out was a patient seeing several GPs in the same practice and not having that continuity of care. And of course, our practices have got bigger. We're working in groups. We make perhaps better notes than we used to, so we share information between our colleagues. So GPs should be able to pick up a clinical problem and have good notes to look at on the system. So we should be able to, as a team, be able to provide a good care for our patients. It doesn't always work out as patients would want, and I can't pretend that everything is perfect in terms of care. But having said that, I think most GP practices work as teams, perhaps of 8 or 10 doctors, and we do have to share the workload and communicate with each other via our note-keeping systems. And I think overall it does work. The old days when you had one GP working on their own in isolation, I think they're almost over, apart from some very rural parts of Dorset. We don't have many single-handed practices left, and I think the better practices, in my experience, and I've been a GP for 33 years, are when GPs work together and support each other in groups. And I see that care as being better. When I started in general practice and trained as 1979, the quality of practice was nowhere near what we can expect these days. And I think the public expectation has changed during that time. I've seen massive changes in the health service. I hope we deliver good quality care in most of our local practices. I think in Dorset we're very lucky in the quality of general practice. Simon, do you want to add to that?
Yeah. All I would add really is in the future, moving forward from the future, and the continuity aspect, I think there's a growing realisation amongst GPs locally, even though we might not like it, is that actually we do need to look at moving towards a 7-day working practice. Not all my colleagues are particularly happy about that, but times are changing, people's needs are changing. This is what this is all about, and putting the patient at the centre of it. And actually, if that means that you have somebody there doing general practice 7 days a week, so be it. That's what has to happen, I think. It's happening in the hospitals. So why should we be, why should the hospitals have to move to 7-day working and us say, no, we're just going to stick doing our 5 days a week? Now, that doesn't mean me necessarily sitting in my surgery 7 days a week. Now, much though my patients might like me to be there 7 days a week, I'd like to have a few days off. So it won't necessarily be me. And again, this comes back to the IT system, because actually if we've got a joined up IT system, then actually when I'm not there, when somebody comes in on the Wednesday, because I'm not there the Wednesday because I was working on the Saturday, then somebody comes in and says, oh yeah, they saw Simon and they've done this, this and this so far. So yes, the continuity, I think we appreciate, that has to change. And that's where we're looking at in terms of the 7-day working.
Thank you. Marjorie Houghton, I'm just a patient at one of the surgeries.
Not just a patient.
What you were just saying about the doctors doing longer hours, does that mean they would be later in the evenings as well for the people who work and don't have the opportunity to go to the surgery during the day?
I think, well, there isn't an answer at the moment. But what I would, in my brain, what I'm imagining in terms of routine care, I think you're probably looking at 8 to 8, 7 days a week. So, I mean, we get talked about that GPs do 9 to 5. It's actually already 8 till 6:30. So we're talking about an extra hour and a half on that Monday to Friday. But I think actually it's that joined up over the weekend that's probably the important bit in addition.
Could I just say one thing about the hospitals? I've just had cause to go to A&E with a friend. And I think until someone has experienced and seen what the hospitals have to go through, you don't really appreciate. You can read it in the newspapers and people can tell you, but you do not appreciate how bad it is until you actually go there. But one of the things I was really surprised at, because in the press they're saying about the ambulance service, and I'm sure you've gone into that. Now, I didn't realise until Tuesday that the ambulance people have to stay with the patient until they can hand that patient over to a nurse. Now, I saw with my own eyes that they were there for 1 hour with a patient because there wasn't a nurse, because they were so busy, there wasn't a nurse to hand them over to. Surely something needs to be done about that.
Well, yes, and I think there are two bits to this. There's the here and the now, and to be honest, the clinical services review isn't going to answer the here and the now and the pressures that we're experiencing this winter. What I can say is there are separate avenues that are being explored at the moment to address the here and now, but actually that's a slightly separate argument to the clinical services review itself.
I think it's important as well for GPs to work closely with A&E departments. I myself am working this coming Saturday evening in Bournemouth A&E as a GP, helping the pressures that are facing A&E at the weekend. So, and a few GPs, and we have plans actually to look at how we can, primary care can work with secondary care, particularly in the accident department, to solve that problem of emergency access. So I think it's just a plan in process.
Thank you very much. My name is Tony Hillman, and I'm here representing Action on Hearing Loss, which is the snappy new title for the RNID, or not. I just wanted to raise hearing loss. I know it's probably the wrong meeting to be doing so, and I have talked to Francis about this, and I know there's going to be more coming in implementation, etc. It's just something that struck me when you were going through your groups, and one of the things you raised was the idea of taking care of your own health. And I just wanted to put a couple of statistics, and also, obviously, the ageing population. There's a couple of statistics. 9 in 10 people's hearing will get worse as they get older, 90%. So the increases in heart disease and all the rest of it are dwarfed by the hearing loss issues. And obviously, there's going to be a 30% increase in over 70s. And also, statistics show that people with hearing loss, because of some sort of embarrassment factor, I wear 2 hearing aids myself, take about, on average, about 10 years to seek help for their hearing loss, even though they know there's something wrong. It's embarrassing. I don't know why. I don't find it embarrassing, but a lot of people do. So it would strike me that as something that is part of your your review in terms of, and I did read through the base statistics that you've come out with. There was not one mention of hearing loss, and it does affect 9 out of 10 people as they get older, which is what's happening in Dorset. So it does strike me as something that, and could be a preventative measure if people were encouraged to get through. Just to say, other CCGs are contemplating giving people one hearing aid instead of 2 as part of their money saving when we've come to the scientific conclusion that people have 2 ears. And so actually, when you've got hearing loss, it's probably a good idea to have 2 hearing aids for all sorts of reasons. Francis tells me that we're not at that stage. That Devon, other CCGs have been contemplating this, and I just want to put a marker down to say that I don't want that to happen, that the audiology service in Dorset, as I perceive it, is very good. And so I just wanted to raise that topic.
Thanks. And we'll certainly feed that back. And if you want to feed that back as well in writing, that would be good.
I'm Robert Yexley. I'm one of the over 70s in Dorset. And I was born before the NHS came into being, as a lot of people have been, and been lucky enough to have my family looked after for all that time. I noticed that in your presentation today that you did, in the first presentation, cover what would happen more towards the end of your review, where you'd actually sorted out what you need done in groups. I think there were maybe 10 of them, I can't remember, that's not important. And then they would be put out to bid by private healthcare companies and the NHS to bid against each other. And the action on those would be awarded to one or the other. That is correct, isn't it?
I'm not sure we covered the bidding in the presentation per se, but let me address it right now. So we're working with all of the NHS health providers in Dorset, including ambulance, on this review. So we have the 3 hospitals, we have the community trust, and we have the ambulance service, and we're also working with Public Health England. So the point about education, involvement in education, which we picked up earlier, that's a massively important part. It used to be part of the NHS, it's now part of local authority, but we are involving that. As we get through the review, and currently we have a tiny percent, I just want to share where we are now, currently we have a tiny percent of private providers where we've approached NHS organisations, and for whatever reason they can't provide the service that we've asked to be provided because that's the right thing for patients. So we have some services like that, and I'm sure, and that's reflected around the country, but that's currently our position. Our intent going forward is to reiterate the process. 750,000 people, of which you are a sample tonight. We're looking at your long-term care requirements. We're looking at what the right services to provide are, and then we're going to ask our NHS providers, what of these services can you provide? And then what do we do when they can't provide them? We've currently also got the Health and Social Care Act, which is a legal requirement as a commissioning organisation to go out to offer our services for anybody who satisfies the quality and the service provision for patients. So that is a legal requirement that we need to go through. So we still have to do it, but we see at the moment is the NHS service providers in Dorset are fantastic. And they're providing the services that we've got, and for that tiny bit they can't, we then have a legal requirement to go out and say, as a commissioner, well, how else do we get it? But it's absolutely so. So if your question, because it felt it was leading towards moving to much more private providers, that's absolutely not our intent.
That's not what was said in the first meeting. The first meeting said that each section will be put out to bid by the National Health against a private healthcare company. That's what you said.
It's any qualified.
Okay,
there's a legal requirement for qualified providers.
But the word bid was used.
Right. Okay.
And I asked questions about it at the time.
Okay. I can't. Okay.
And I asked you about the budget for the consultancy that you have, McKinsey.
Oh. Okay.
And now you're saying that didn't happen, and it did.
No, I'm sorry. I don't think I said it didn't happen. Yeah. I said it didn't happen in this presentation. I thought when I heard your question initially, you said in this presentation.
Because the question is, if that is the case,
yeah,
and then a large portion of this review is handed over to private healthcare companies, that will create a very big redundancy program for the NHS people, as it started in Hampshire, as I'm sure you're aware, and that will be a lot of money.
Yeah, no, let me just finish.
Right, in terms of redundancy, and when those people are made redundant, they will then, where do you think they will go? They will go to the private healthcare companies.
I think I could only reiterate what Phil said. It is actually, I certainly didn't say this last time, but I'll say it to you now, that there is no intention for us to wholesale privatisation of the NHS. We have very good NHS providers in Dorset at the moment, and we intend to use them. Their function may change, because our hospitals aren't going to stay exactly the same as they are. We're talking about more care moving out into the community. But actually, we actually think our hospitals are likely to be providing some of that care in the community. So they won't be stuck just with the hospital, but it will still be the NHS. As I say, it's not our intent to look at wholesale privatisation of the NHS.
Thank you.
Hi, my name's Alison Dalton. I'm a church-related community worker working in Poole. I think we've just heard that a lot of people have passion about health because it's important to them. But actually, my experience coming to some of these sort of meetings is you get a restricted view from these sort of meetings, but people are self-selecting. I understand that you are consulting as widely as you can, but there are plenty of people who are healthy at this moment who do not even know you exist because they are healthy and it is not in their mindset, or who are at a different level of life where their lives are too chaotic or whatever, you are not going to hear the message of. And to be that proactive, and I'm not saying you're not doing this, I'm asking the question so the wider people get to hear. It costs and it's hard to be that proactive. So I'm just double checking that proactivity is happening and that you are hearing all of those voices too.
Thank you very much. You're absolutely right. What would be brilliant would be 750,000 people in the room. There might be a bit of a squeeze, but you're absolutely right. So what we're trying to do is to try and spread the word in a number of different ways. So last week, Simon did a BBC interview at 7 in the morning for hopefully trying to catch those travelling to work in the car who listen to the radio. So we did try to do that. We're in active discussion all the time with the Bournemouth Echo and the Dorset Echo, so we're trying to get the conversation going there. We're trying to do events like this, and a lot of people that come to events like this, some are individuals, which a number of you are, but some represent a larger group and have your own networks of people who you can talk to, and we'd encourage you to spread the word as best you can. We're trying to use some of the social media to help us do that. So we're running Twitter. We've been tweeting tonight about what we're doing. We're running Facebook. We've got a website, as well as what Francis talked about earlier is actively approaching people we know already, but also really welcoming any groups approaching us. We're trying to get to some of the hard-to-reach communities. We're trying to reach out to travelling communities, for example, which are notoriously hard to reach. But there's a massive group of the Dorset population who currently don't think they need to be involved in the discussion. And you're absolutely right; they do need to be involved in the discussion. But if you accept the 6 degrees of freedom argument, then we know somebody who knows somebody who knows somebody else, and 3 or 4 connections out, we know about 1 billion people. So so if you could, for future events, friends and family, anybody you know, any groups, it's not there's no restriction on this, and we'll just expand to fill. We have run one event in Bournemouth at the football club. We did it in the room, but I'm happy to move it into the pitch if we need to get that number of people. But it's trying to do that. And just to finish, I just want to finish quickly, is what would help us is help us with the language, help us with what would get people engaged. Is there a word or a few words or a phrase which, if we were to share that, they say, well, actually, I need to say something about that.
So can I give you enough, myself and Paula here? We do a couple of networks which are very grassroots. Liz did something about the CCG for us. Hopefully she would say they're worthwhile. I'm not sure she would. But there could be an offer for you there.
Thank you.
And you'd reach 50 to 100 people that you wouldn't reach otherwise.
Brilliant. Yes, we'll immediately accept your offer. Thank you very much.
Thank you very much.
I mean, I think we ought to mention also that the CCG is very much a GP-led organisation. GPs do know, hopefully they do know their patients, hopefully they do represent their patients' interests in those local communities. And I think that GPs will feed back concerns that they know their patients have. We've gone out to all the GPs, we've disseminated the consultation quite widely amongst the GP workforce. So every general practice will have been represented and be able to feed into this process. And I think they feed in, very often they feed in their own patients' concerns. Yeah.
About people like me who are healthy,
yeah.
Goes to my GP perhaps once a year.
Right. Well, I think that's right. I think that those GPs those patients who go once a year to the GP, I think the GP will listen to those patients.
They don't even know you exist at this moment.
Okay. Well, point taken. Yeah.
Just to add to everything that Phil said, and as you heard, we've got lots of plans afoot. We're also hosting a number of sessions with the general public to co-design the consultation for that very reason. And one of the questions I'm going to be asking is exactly what you said to me. We're aware that there's a working well out there that we're not accessing. They are seldom heard, they are hard to reach. There are people that aren't engaging. We need to engage with them, or at least give them the opportunity to have their say. So we very much like to take you up on your offer, yes please. And I'm having a meeting with the 150 Supporting Stronger Voices reps to co-design and ask them, how do we get out, how do we reach out? And already I've started conversations, lots of different ideas like road shows, like one day talk to everybody who touches the NHS and give them all a consultation pack, lots of different things coming in. I'm liaising closely with Healthwatch as well and getting their advice. And as you mentioned earlier, the Dorset Race Equality Council, the Councils for Voluntary Services and so on and so forth. So thank you. Yes, please. And let's keep talking. Thanks, Sue.
Time for one more, I think.
Can I just say I'm representing the elderly group here, a lot of us here. I was a district nurse many years ago, and I sit here and listen, and we went through all this sort of thing in those days with Project 2000. Don't know if there's any nurses here of my age group that will remember that. Thousands of pounds were spent on that. I can remember having to go on a time and motion study. Nothing for 2 weeks. We had to drive in our cars and record how long we took to take from getting out of the car into the opening the gate, to get from the gate to the house. We spent hours doing that and nothing was used. It was all a waste of money. I sit here a little bit disillusioned, but hope that you can, because I live in sheltered housing now. I'm an old person, and I live in sheltered housing now. I've got an iPad, and they think I'm very clever because I live with people older than me, and that's how I came to know about you. And I've always been interested in anything medical and still am. The brain's still working, but the body's not so good. But I can go back and talk to my elderly people just up the road here in a sheltered housing, and they won't know what I'm talking about. But it does involve us. I get scared now because I'm going to be old. Well, I am old. And I'm going to get older, and I'm getting very scared because of things that I listen to. I've been looking after my sister with pneumonia for 11 days, and she is left now in limbo. She doesn't know whether she's going to get any help or whether I, as an elderly person, we old are looking after the old. That's the problem. So there are so many facets of this conversation. I could talk for hours, but I won't.
Can I try and sort of answer this? I've not been introduced. I'm Chris McCall. I was a GP for 30 years in the area. I'm sorry I was late to the meeting. What you were saying was echoing what I feel, because 30 years in the NHS, I've seen so many reforms and changes, or attempts which haven't achieved anything. Now, I've not been a GP for 2 years. I regret not being a GP now, because I strongly believe that this, what we're going through here in Dorset, will be the first time in 30-odd years of working as a GP that will produce the changes that people will actually see a different and a better healthcare service. I mean, we all are users at the end of the day. Whatever profession we are, we're all potential healthcare users. And like you, as I get older, I'm going to become a greater user. And if I'm in Dorset, if I can influence a better service for me and my family, then I will do my utmost to do that. And my colleagues sat around the table here, on the desk here, who are involved, they have that passion. And they really do believe that this CSR, Clinical Service Review, is the first time in a lifetime, since really the inception of the NHS in 1948, that we can make a real big difference. Because up to now, you're quite right, the NHS has not been good at implementing change and implementing developments. In Dorset, we've been better than most areas of the country, but we can do even better. We can have excellence and strive for excellence across the patch. And in Dorset, we've got the basic building blocks that can achieve that. And it is going to be an NHS. It's not going to be a private health service. It is going to be an NHS health service. It will look different, but it will be better. And we do need to get everybody's views, those who don't even use the service. But as has been explained, you know, we're trying our best to get those views. As a GP, I always wanted to know the people who didn't come and see me, what they thought. You know, when they do need to come and see a doctor, what do they want out of the doctor? I knew very well what most of my patients I saw 3 times a year wanted, but it's those who don't. But, you know, people are really trying hard to make this mean something fundamentally different and better for Dorset.
Could I just say too, that the human body, all through the ages, we have the same needs, the same care. We need to be washed, we need to be hugged sometimes. I've been a widow for 24 years. We all need these basic human needs are there, and we still need it, and that will never change. Even the Queen has to go to the toilet. She might have a cushion on it, but...
I can tell you an anecdotal story about the Queen, because I worked with the Queen's physician when I was trainings, but I won't go into that now. But you're absolutely right, and I think one thing perhaps that also hasn't been emphasised is, whilst we're working as an NHS, we are incredibly conscious that actually we're not talking about healthcare, we're talking about care, full stop. And another thing that's been happening recently, and along parallel lines, which I think will converge into this, is the NHS is working much more closely with our local social services departments and our local authorities to really have better integrated health and social care services. Because, you know, a lot of care of elderly people isn't about health, it is about what you're talking about. It's about the holistic approach for their whole social needs and personal needs. Absolutely. And I agree with you, nothing came out of that. Let us make a change this time.
We're going to have to wrap it up there, I'm afraid. We're not disappearing, so if anybody had a question who hasn't had a chance to ask, if they want to come and grab us afterwards, we're more than happy to have a chat with them afterwards. Just a couple of quick things. This isn't the end of it, so what happens next? We've had this month's meetings. These are the meetings next month. You don't have to write it down because you can go to our website here or give us a ring if you want for some more details. I would strongly recommend anybody who's semi-internet literate to have a good look on that website. All the information is there as to what's happened so far. You'll see the need to change documents on there. You'll see everything that's happened so far in terms of previous events and what's happened, and information. All the data that was there is actually on that site as well. So I would strongly recommend people to go there. Before you go, just a very big thank you. The turnout's staggering tonight. I'm really, really impressed. Next time, we've seen more people this round than we did last time, and I'd like to think that we see more people next time around as well. So if you can all bring a friend next time, that would be good, and we'll see you all in a month's time.